Welcome to the Deep Dive. Today, we are taking on a subject that is, well, it's simultaneously historical, acutely relevant, and maybe one of the most challenging areas of acute care out there, conflict surgery.
It really is.
Our mission today is pretty direct. We're going deep into a single, comprehensive source, Chapter 34 on conflict surgery, from Bailey and Love's Short Practice of Surgery.
A classic.
It is. And if you're looking to really master this material, for revision or for clinical prep, or even just to understand the brutal evolution of trauma medicine, this is your shortcut. We're going to structure the knowledge, pull out those critical distinctions between military and civilian care, and really dissect the physics of modern warfare.
And we absolutely have to start with just how ancient this field is. The link between surgery and war, it's the cradle of trauma medicine. There's that famous quote from Hippocrates around 460 BCE. "He who wishes to be a surgeon must first go to war." And that wasn't just, for dramatic effect. It was a real recognition that the battlefield was the ultimate high-stakes environment for honing surgical skill.
And it goes back even further than that, doesn't it?
Oh, much further. The treatment of war wounds is documented in the Edwin Smith Papyrus. That's the oldest known treatise on trauma surgery and anatomy, and it dates all the way back to 1600 BCE. So for, almost 4,000 years, surgical progress has been directly linked to human conflict.
That continuity is incredible. But the source points to a real pivot point, a figure who took that chaotic battlefield care and actually turned it into a system.
You're talking about Domine-Jean Leray.
Exactly. Napoleon's favorite French battlefield surgeon. Why does he get the title of the first modern military surgeon?
Well, because he understood something fundamental. He knew survival was less about the specific skill of the incision and more about the speed of access to care. Larry saw that delay was the enemy.
So he didn't just operate, he built the system around the operation.
Precisely. He created the ambulance volante, the flying ambulance. These were fast, horse-drawn carts designed to get casualties from the point of wounding to a field hospital for immediate surgery.
Which is profound. I mean, that's a complete shift from a stationary hospital just waiting for casualties to arrive to an active forward system of retrieval.
It is. And his work laid the foundation for two concepts we just take for granted now: organized casualty evacuation, and, maybe most importantly, formal triage. His method treating based on severity, not on rank, that's the very backbone of everything we're going to talk about today.
Okay, so if the history is the backbone, then understanding the operational environment, that's the muscle. The second a clinician moves from a civilian trauma center to a deployed environment, they have to know the rules has completely changed. The source lays out 5 core contrasts.
Yes, and these are absolutely fundamental. They mandate a complete philosophical shift.
So let's establish them. What's the first one?
The first difference is the austere environment. While conflicts in the last 20 years have sometimes featured these incredibly sophisticated, hard-built Role 3 hospitals, those are really the exception.
Not the rule.
Not the rule at all. The default reality is severe logistical and personnel restrictions. What that means in practice is that you have to rely on your raw clinical skills, your hands, your eyes, your physical examination.
Because the high-tech toys aren't there.
They're often just not available. Routine access to CT scanners, advanced labs, interventional radiology, the things we lean on so heavily in a level I trauma center, they might be delayed or simply not exist where you are.
Which means that austerity amplifies the second difference, that the environment is hostile and dangerous.
Always. In civilian trauma, the mantra is seen safety first, then patient care. In conflict surgery, ensuring the safety of your medical personnel is paramount, but it's never, ever guaranteed.
And that's a key distinction.
It is. Modern forces have learned that moving physician-led teams, what they call forward surgical teams, or FSTs, much closer to the fight dramatically improves survival. But that forward deployment inherently increases the personal risk. You're part of the fight, not protected behind it.
Okay, so we have an austere, dangerous environment. The third difference is the nature of the wounds themselves, the injury patterns.
Oh, they're in a different league entirely. A civilian center might see high-energy trauma from a car crash, maybe a low-velocity gunshot, but the wounds from modern high-velocity ballistics and large-scale explosives, they transfer a monumental amount of energy.
So tissue destruction is just on another level.
Completely. The cavitation, the multi-system involvement, the sheer volume of dead tissue, and the degree of contamination is far beyond almost any civilian injury.
And that leads right into point 4, the constant threat of a mass casualty situation.
And this is where triage becomes absolutely vital. In a civilian setting, your goal is everything for everyone. You exhaust all measures for every single patient.
But you can't do that in a mass school situation.
You simply can't. The military dictum takes over. Do the best for the most, not everything for everyone. It's a difficult ethical shift. You have to allocate finite resources, theater time, blood, ICU beds to maximize survival across the entire group of casualties. And that might mean some non-salvageable patients receive only minimal palliative intervention.
A brutal calculation.
Yeah.
And the fifth contrast is that war surgery is usually delivered in stages.
Yes, this flows from everything we've just discussed. The care is rarely definitive in the first instance. You are entirely focused on damage control principles.
Stop the bleeding, stop the contamination.
That's it. You perform an abbreviated surgery specifically to stabilize the patient so they can tolerate being moved to the next echelon of care. If you do too much, too early, you risk killing them in the OR or delaying the evacuation of others. So careful planning and clear communication up the evacuation chain are non-negotiable.
Now, these operational differences, they're not happening in a vacuum. They're governed by a framework international humanitarian law.
IHL, yes. It's the regulatory backbone for armed conflict, derived mainly from the Geneva Conventions. And it's crucial because it governs the most complex ethical situations a doctor can face. It grants specific rights, like protection from being targeted, but it also imposes critical duties.
And the central duty is about who you treat.
It is. The central mandate is absolute. Treatment must be based solely on medical need. Nationality, race, class, politics, religion, none of it can play any role in your immediate decision-making.
Which leads directly to that core dilemma: treating your own forces and enemy combatants, often side by side in the same facility.
Exactly. And the initial medical treatment is the same. A penetrating chest wound is a penetrating chest wound, regardless of the uniform. But the downstream logistics, they have to change.
So once they're stabilized, the paths diverge.
They do. An enemy combatant usually can't be evacuated back to a highly specialized Role 4 facility in your home nation. Their onward transfer depends on local host nation capabilities or maybe international organizations like the Red Cross. It's entirely dependent on the local security agreements.
And that brings up an even more complex ethical point, especially when treating local civilians.
It's a profound conflict, and it can lead to a kind of moral injury for the surgeon. The source gives a classic, heartbreaking example. You perform a technically brilliant revascularization to save a local patient's limb. A surgical success. But if that patient lives in a country with no long-term rehab, no chronic wound care, no follow-up surveillance, have you really provided the best care? You saved the limb, but they may be doomed to chronic infection or even a later amputation because the support system just isn't there.
So that calculation has to become part of the triage process itself.
It does. Is that resource better spent on a different patient for whom the intervention will actually lead to a functional recovery? It's a calculation civilian surgeons almost never have to make. And just to round out the IHL point, while medical facilities are protected under the law in modern unconventional warfare, security has to remain the absolute highest priority. The guarantees of law can clash with the reality on the ground.
Okay, so to manage this flow of casualties through this complex environment, the military uses this strict R1 to R4 system, understanding the capabilities and, just as importantly, the limitations of each role is crucial.
It is. This role system provides standardization. It's the operational blueprint for trauma management in a multinational environment.
Let's define them then. What can each role do and what can't it do? Let's start at the very front line. Role 1.
Role 1, unit level, is the most forward and basic tier. This is often just a combat medic or a physician's assistant integrated directly into a small unit. Their crucial wartime function is specialized first aid.
So, stopping the bleeding. Tourniquet.
Exactly. Tourniquets, basic resuscitation, field triage, and stabilization. Think basic life support, advanced trauma life support. They cannot do surgery. Their entire job is to buy time for evacuation.
And moving back from there, we hit the first level with actual surgical capability.
That's Role 2, intermediate capability. And this is a massive jump. Role 2 facilities can receive and re-triage casualties from Role 1. They offer much higher level resuscitation, including blood products, not just saline.
And this is where we find the surgeons.
This is where you find the forward surgical teams. They are capable of performing damage control surgery, DCS, abbreviated procedures focused only on stopping life-threatening hemorrhage or contamination. They're designed for speed and stabilization, not definitive care.
And then Role 3. Historically, this has been the main deployed hospital.
Role 3, deployed hospital care, is a robust, mission-tailored hospital. In recent conflicts, these have become incredibly sophisticated, often hard-built facilities that are functionally equivalent to a Level 2 civilian trauma center. They have a full range of specialties and provide primary, definitive surgical care. They handle the vast majority of the surgical workload in theater.
So if R3 is the trauma center, R4 is the strategic long-term recovery center.
Exactly. Rule 4, definitive care, provides the full spectrum of definitive care. Complex neurosurgery, rehab. This is typically back in the casualty's home nation or a major allied country. It's for injuries that are too complex or require too much time to manage at the forward R3 level. This phased movement from R1 to R4, that's the logistics of survival.
And the lifeline that connects all those roles is medical evacuation, medevac. It's not just transport, it's critical care on the move. And the big game changer has been aeromedical evacuation, right? Helicopters and planes.
Indispensable. But it introduces its own set of significant physiological challenges. You can't just, throw a patient onto a helicopter. The source highlights several critical pre-flight preparations.
Okay, what are they?
Well, first, the patient has to be stable enough for the entire journey. Airway and breathing must be secure. All your lines and tubes, IVs, chest drain, catheters have to be robustly secured. You don't want something pulling out mid-flight. And you absolutely have to mitigate hypothermia. Blankets, fluid warmers, it's all mandatory.
And then there's the physics of altitude. Even in a helicopter, that can have a huge effect on certain injuries.
This is where we worry about thoracic barotrauma. It's a risk caused by changes in atmospheric pressure. Any gas trapped in a contained space, like a small, hidden pneumothorax, will expand as the aircraft gains altitude.
And that can turn a small problem into a life-threatening tension injury.
Instantly. Because of this risk, military protocol often dictates that any patient with significant chest trauma or blast lung should have a prophylactic chest tube placed before a long flight. It's a direct response to the transport environment.
And all of this is a race against the clock, dictated by the golden hour principle. Now, the exact timing is debated, but the core concept holds up.
It absolutely does. The military data confirms it starkly. The majority of preventable deaths happen in the pre-hospital phase, often within minutes of injury. Survival is a direct function of how quickly you can get to a surgeon.
So we have two main strategies to beat that clock. We either shorten the time to get to surgery,
or we find ways to lengthen the golden hour itself.
Okay, so shortening the time, that's a logistics problem. Faster helicopters, pushing surgical teams further forward.
Right, or using things like telemedical support, where a specialist can guide a medic at the front line. But lengthening the golden hour, that's the biological strategy.
What does that look like?
That's about pushing resuscitation capabilities right to the point of wounding.
Yeah.
It's the widespread, immediate use of tourniquets. But the most significant advance is giving medics pre-hospital blood products, actual blood or plasma, not just saline. Starting true hemostatic resuscitation before they even reach a surgeon can genuinely extend that critical window of survival.
And the science of survival has to constantly adapt to the science of destruction. Weapon technology drives the injuries we see. So how have the injury patterns in recent conflicts like Afghanistan and Iraq changed from older conflicts like WWII or Vietnam?
The shift is dramatic. If you look at the historical data, it was pretty predictable. Infantry soldiers got shot about 90% ballistic injuries. Air personnel got more blunt trauma and burns.
But modern conflicts look very different. Why?
Well, the main reason is widespread personal protective equipment, body armor, and helmets.
Yeah.
What we see now is that thoracic and extremity injuries are actually less common because those are the areas protected by armor.
But the flip side of that...
The flip side is that head and neck injuries have become far more common because they remain the most exposed areas.
But the truly transformative shift, the one the source really emphasizes, is the mechanism of injury itself. It's not just bullets anymore.
Not even close. We're dealing with bombs. If you look at the U.S. Civil War, it was 91% gunshot, 9% explosion. Fast forward to Iraq and Afghanistan. That completely inverts. Only 19% were gunshot wounds. A staggering 81% were caused by explosion.
81%. That changes everything.
It does. And this dominance is almost entirely due to the improvised explosive device, the IED. They're cheap, easy to make, and the knowledge is widespread. The source is clear. IEDs are the signature weapon of contemporary and future conflicts. So the modern war surgeon has to be a master of blast injury.
Okay, so given these horrific injury patterns, where 81% of trauma is from explosions, the surgical strategy has to be fast and focused. We know battlefield deaths are either immediate from brain injury or bleeding out or late from infection. What's the #1 intervention?
Hemorrhage control. It is the absolute unequivocal mainstay of military trauma care.
And For extremities, we have tourniquets. But the really lethal problem is non-compressible torso hemorrhage.
It is. Internal bleeding in the chest or abdomen carries a truly grim prognosis. And this is where we're looking for new technologies to bridge that gap to surgery. Things like Reboe resuscitative endovascular balloon occlusion of the aorta.
Explain that for our listeners.
So you thread a catheter up the femoral artery and inflate a balloon inside the aorta. It's essentially an internal tourniquet. It clamps off the blood supply to the pelvis and abdomen, buying you critical minutes to get to the operating theater.
But no matter the tool, the overriding philosophy is damage control surgery. DCS. It's all about prioritizing physiology over anatomy.
Exactly. You stop the bleeding, you stabilize the patient, and you worry about the fine details later.
And this philosophy is broken down into 4 distinct phases.
Yes, a very structured sequence. Phase 1 is recognition and resuscitation. This is the key decision point, recognizing the patient is on the brink and needs damage control now. That means rapid intubation, aggressive rewarming, and moving straight to the operating theater.
Then phase 2 is the immediate surgery, the abbreviated tactical part.
Right. The focus is purely on rapid control of bleeding and contamination. You pack the abdomen, you temporarily close the wound, maybe just with towel clips, and you get out. You are not fixing anything definitively, you're just stopping the clock.
And from there, the patient goes to the ICU for phase 3, stabilization.
And this is where the critical care team takes over. They aggressively treat what we call the deadly triad: hypothermia, coagulopathy, and acidosis. They're normalizing the patient's biochemistry, letting the body recover from the massive shock.
And only once they're stable, they go back for phase 4, definitive repair.
In phase 4, you go back in and perform the definitive repairs, bowel resections, vascular grafts, complex orthopedic work, and this might take multiple trips to the OR over several days. If the patient's physiology starts to waver, you stop, and they go back to the ICU.
But the source adds an important caveat here. DCS is life-saving, but it's incredibly resource-intensive.
It is, and you have to be careful not to use it too liberally. For a patient who could tolerate a definitive repair up front, putting them through the whole DCS pathway adds significant risks: hernias, fistulas, infection from those multiple trips to theater.
And DCS surgery doesn't work without its twin, damage control resuscitation, or DCR.
They have to happen concurrently. DCR is all about managing the physiology of the bleeding patient.
So what are the principles?
3 key things. First is permissive hypotension. The idea is to keep the blood pressure deliberately low, maybe a systolic of 90, until the bleeding is surgically controlled. The fear is that a higher pressure will just blow off any early clots.
But there's a risk with that, especially with long evacuation times.
A huge risk. Prolonged hypotension is harmful. It's a fine balance. The other 2 principles are linked: the avoidance of crystalloid, so no saline, and the proactive management of acute traumatic coagulopathy. Crystalloids just dilute clotting factors and make the patient colder and more acidotic.
So instead of saline, we use massive transfusion protocols, or MTPs.
Exactly. War injuries, especially blast, cause massive blood loss. MTPs are designed to replace what's lost in a balanced ratio of red cells, plasma, and platelets, often 1.1.1, to mimic whole blood. You're replacing clotting factors, not just oxygen carriers.
And the success of that depends entirely on having a sophisticated blood bank and supply chain.
It does, which was a hallmark of the Role 3 facilities in recent wars. And the future is even more interesting, using fresh whole blood from walking blood banks in forward areas. But this all ties back to that austere environment. At Role 1 or 2, you might have 5 casualties and only 2 units of blood. The decision then might be to evacuate immediately rather than try to stabilize, just to get them to a place with more resources. So now we need to shift gears a bit, from the how of surgery to the what of the injury. You can't manage these wounds effectively without understanding the underlying physics, which is a whole different world from civilian trauma.
Right, this is where surgery meets physics. To understand the wound, you have to understand the whole trajectory. Let's start with internal ballistics. What happens to the bullet inside the weapon?
That's where the propellant ignites, the gas expands, and the bullet is forced out. And the key feature inside the barrel is rifling.
Those spiral grooves.
Those spiral grooves. They're not just for show, they impart a spin on the bullet. That spin is what stabilizes it in flight, like a quarterback spiraling a football. It's what makes it accurate.
Then we have external ballistics, which is how the bullet behaves in the air. And military rifle rounds are very different from pistol rounds.
Very different. Rifle cartridges have much more propellant, so they're faster, they stay supersonic for longer, and they're accurate over huge distances, sometimes 1,000 meters or more. The type of round also matters. A full metal jacket is designed for penetration. A soft tip or hollow point is designed to deform on impact.
And that deformation is key to how it transfers energy.
It is. It rapidly dumps all of its kinetic energy into the tissue, creating a massive wound, but it has less ability to penetrate through armor or a body.
Which brings us to the most important part for a surgeon, terminal ballistics, the interaction with tissue.
This is all about energy transfer, and because military rounds have so much more velocity, they transfer a monumental amount of kinetic energy, which is why the wounds are so much more severe.
And to manage them, you have to visualize the two different wound cavities that are created. Let's start with the one you can see.
That's the permanent cavity. This is the track of definitive tissue death, the tissue the bullet physically crushed and tore on its way through. With high-energy rounds, which often tumble and fragment, this permanent cavity can be much larger and more irregular than the bullet itself.
But the truly devastating injury is often the one you can't see, the temporary wound cavity.
Exactly. This isn't tissue the bullet touched. It's the space created by the explosive lateral stretching of tissue as the shockwave passes through. It's like dropping a stone in a pond. The tissue is violently displaced outwards for a few milliseconds and then collapses back in.
And the damage from that depends on how elastic the tissue is.
Precisely. Tissues with good elasticity like skin, muscle, the lungs can stretch and rebound with minimal damage. But tissues with poor elasticity like the liver, the spleen, or the brain, they can't handle that stretch. They shatter, they fragment.
And hollow organs like the bowel.
They're highly vulnerable. Even though their walls are elastic, the fluid inside them is incompressible, so the shockwave is transmitted through it instantly, leading to rupture and perforation.
And this is why you can't manage military gunshot wounds the way you might in a civilian setting.
Absolutely not. The energy is higher, the tissue destruction is greater, and the contamination is guaranteed. In the military setting, the rule is that almost every penetrating wound needs to be surgically explored under anesthesia.
And the damage control philosophy comes back into play here.
It does. You perform the initial surgery, you control the bleeding and contamination, and then you wait. That interval period in the ICU is critical because it allows the full extent of that permanent wound cavity to declare itself. Necrotic tissue isn't always obvious immediately. Waiting gives you a clear line of demarcation, so you know exactly what needs to be debrided before you attempt a definitive repair.
Okay, let's transition from ballistics to blast, which, as you said, is now the overwhelming majority of injuries. What exactly is an explosive?
It's a substance that undergoes a very rapid chemical reaction, transforming from a solid or liquid into a massive volume of gas, liberating enormous amounts of energy.
And we split them into low and high explosives.
We do, based on the speed of that reaction. Low explosives burn at a subsonic speed, a process called deflagration. Think gunpowder or gasoline. They cause burns, but not the classic pressure wave injuries.
The classic injuries come from high explosives?
They do. High explosives degrade via detonation, which is a shock wave moving through the material at supersonic speed. TNT, C4, plastic explosive. They degrade violently, creating a sphere of super compressed air, the blast wave.
And that moving sphere of air is the blast overpressure, a huge, instantaneous pressure spike followed by a rapid fall-off.
And the environment is everything. In an enclosed space, a room, a vehicle, that blast wave reflects off the walls. Those reflections sustain the high pressure for much longer, which massively increases the severity and range of the injury.
And at the same time as a pressure wave, you get fragmentation.
Yes. The physical debris thrown out by the blast, it could be the casing of the bomb, things added to it like nails or ball bearings or just stuff from the environment like glass and stones.
And the signature weapon is the IED. Within that, you have specialized devices like explosive form projectiles or EFPs. What makes them so lethal against vehicles?
EFPs use a shaped charge to turn a metal plate, usually copper, into a high-velocity molten jet. It's designed to punch through armor. The injury to the people inside is twofold. First from the jet and the hull deforming, and second from the massive, rapid acceleration and deceleration of the entire vehicle, which causes severe blunt trauma, like a catastrophic car crash. Because blast is so complex, we classify the injuries into 5 distinct categories. And understanding this classification is crucial because it reminds you that the most dangerous injuries might be completely hidden.
Okay, so let's walk through them. Number 1 is primary blast injury.
This is caused only by the overpressure wave. It's unique to explosions, and it's most severe where air meets tissue. The shock wave literally tears those boundaries apart.
And the most common example is a ruptured eardrum.
A ruptured tympanic membrane, TM, yes. But while it's common, we now know it's not a reliable indicator of more severe primary blast injury. You can have a lethal blast lung with intact eardrums.
So let's talk about blast lung. That's the most life-threatening primary injury.
It is. The shockwave tears the small capillaries in the lungs, leading to bleeding and edema. Clinically, the patient develops progressive hypoxia, which can be delayed by hours. On an X-ray, you see this classic bat wing pattern of infiltrates.
And treatment is mostly supportive.
Mostly supportive ventilation. But you have to be very wary of the risk of a tension pneumothorax or air embolism, especially if you're going to fly them.
What about the abdomen?
Primary abdominal blast injury isn't that common, maybe 3% of cases, but it's very severe. The hollow organs, especially the cecum, are most vulnerable. The presentation can be delayed, progressing to peritonitis as hematomas rupture.
Okay, so that's primary. Next is secondary blast injury.
This is fragmentation, injury from all the stuff thrown by the blast. And the physics here is important. The blast wave pressure drops off very quickly with distance, but the momentum of a fragment decays much more slowly. So you can get lethal fragmentation injuries much further from the blast than you'd get primary blast injuries.
And these wounds are much nastier than a clean bullet wound.
Oh, they're incredibly irregular and grossly contaminated. Management is the same as for any high-energy penetrating trauma: aggressive debridement and delayed primary closure.
Then we have tertiary blast injury.
This is blunt trauma. It's from the patient being physically thrown by the blast wind into an object or having an object thrown into them. Think of it like a massive car crash caused by an explosion. Traumatic amputations often fall into this category.
And quaternary blast injury is a catch-all category.
It is burns from the heat, inhalational injuries from smoke and dust, that sort of thing.
And finally, quaternary blast injury.
Quaternary injury refers to the effects of specific intentional additions to the bomb things like chemical agents, toxins, or radiological material.
These complex mechanisms create very distinct injury patterns. You mentioned the underbody blast in a vehicle versus the dismounted soldier who steps on an IED. Let's talk about those.
The underbody blast-mounted casualty, the person in the vehicle, is often more severely injured overall. The shockwave travels up through the vehicle floor, causing severe foot, ankle, and pelvic injuries. Mortality is very high and usually linked to non-compressible torso hemorrhage, aortic disruption, severe liver lax, and head injuries from the violent acceleration.
And the dismounted complex blast injury.
That's the soldier who steps on the device. It's a devastating but very characteristic pattern. Lower limb amputations, often bilateral, a severe pelvic fracture, and horrific genital, perineal, and rectal injuries.
And the immediate threat is hemorrhage.
Always. Initial management is all about immediate hemorrhage control with tourniquets and proximal vascular control right at the point of injury. Surgically, the goals are to externally fix the pelvis, save as much limb length as possible, and meticulously examine the rectum. Proctoscopy is mandatory, with early fecal diversion to manage the contamination.
And that brings us to the final, relentless enemy in all of this: infection, the late killer.
It is, and war wounds are so vulnerable because they are just grossly contaminated. You have massive tissue destruction combined with soil, debris, clothing, and dirty fragments driven deep into the tissue. It's a perfect storm for bacterial growth.
So how do you combat that?
It starts at the point of wounding with sterile dressings and antibiotics if evacuation is delayed. But the true mainstay is prompt and aggressive surgical debridement of all non-viable tissue.
And how do you do that effectively?
You have to be meticulous. You use extensive irrigation to wash out debris, but critically, the source warns that high-pressure wound lavage is contraindicated. It can actually drive bacteria deeper into the tissue.
And the number one rule for closure?
It is absolute. Contaminated war wounds, with very rare exceptions like facial wounds, must not be closed at the first operation. They have to be left open, managed with clean, moist dressings, and then brought back for serial debridements.
So you wait for the wound to declare itself clean before you close it?
You wait until you are absolutely confident that all non-viable tissue is gone and the wound bed is healthy. That's called delayed primary closure, and it's fundamental. And of course, tetanus prophylaxis is mandated for every single casualty.
What are the main bugs you're fighting?
You have your usual staph and strep, but also aggressive environmental gram-negatives like E. coli and Klebsiella. The real danger, though, is the rise of multi-drug-resistant hospital-acquired organisms like Acinetobacter and Pseudomonas. And in these long-stay immunosuppressed patients, fungal infections can become a profound leak complication. It's a constant battle against a very tough opponent.
This deep dive has taken us across 4 millennia, from Hippocrates on the battlefield to the relentless logistics of modern IED trauma. We've crystallized those crucial differences between civilian and conflict care, defined the strategic R1 to R4 system, embraced the philosophy of damage control, and dissected the terrifying physics of ballistics and blast.
And the core lesson really hasn't changed. Conflict surgery is a study in resource management and, I think, anticipation. The key takeaway for any practitioner has to be the critical importance of understanding the mechanism of injury. You have to look beyond the visible wound and predict the damage you can't see, the temporary cavity, the internal ruptures from blast over pressure. That predictive knowledge is probably the greatest tool you have.
That is a powerful final note. And as we finish up, here's a provocative question for you to consider. How will the continuing miniaturization and forward deployment of medical tech, things like telemedical support with augmented reality or point-of-care blood analysis at a Role 1, how will that challenge or redefine the established R1 to R4 system in the next decade? Will we eventually see Role 1 capabilities start to look like what a Role 2 can do now, and in doing so, fundamentally change the entire evacuation chain? Something to mull over as you integrate this complex and vital knowledge.